Okay, I think we're going to get started. Thanks for joining us again. And today we have Dom, who is our thrombosis fellow this year, presenting for us. And the topic is anticoagulation in renal failure. And it's a topic that I know internally in our group has come up a few times. So go ahead, Dom, and we will save the question and feedback at the end. Okay, take it away.
Thank you for the introduction. So as Tony was saying, my name is Dom. I'm a PGY5 GIM fellow doing thrombosis training this year. I'll be talking about anticoagulation in renal failure. Just want to go over the objectives first. In the beginning, I'll talk about anticoagulation with DOACs in patients with atrial fibrillation in the setting of CKD and end-stage renal disease. Somewhat building on Ben's presentation back in 2022, as well as anticoagulation with either DOAC or low molecular weight heparin with VT in the setting of CKD and end-stage renal disease. The bulk of the presentation will be on objective 2, but I think objective 1 builds into objective 2 as well. Beginning with atrial fibrillation. Some quick background. So as we know, and we've seen on CTU and all communities, the risk of CKD is increasing in prevalence, largely due to the increased risk of diabetes and hypertension. We know that it's associated with several comorbid conditions, but the ones that in particular interest to us is that we know that VT occurs in almost 4% of our patients, and catheter-associated VT occurs in almost 16%. Nonetheless, in atrial fibrillation, it's almost 10 to 20 times higher in comparison to the average population. Studies have shown that almost up to 50% of these patients will experience a bleed, which is 5 to 10-fold rate higher in comparison to the general population. Typically, bleeding in CKD is multifactorial, not only due to the the disease state of the patient, but due to platelet inhibition, due to uremic platelets, etc. Quickly going over the trials that we all know of: RELY, ROCKET-AF, Aristotle, and ENGAGE-AF. Particular interest is in the creatinine clearance subgroups. So in each of these trials, about 15 to 20% of the patients had a creatinine clearance less than 50. In RELY, they found that there was no difference in major bleeding or outcomes or the rates of systemic embolism in patients with CKD. But of note, the creatinine clearance exclusions were either 30 or 25, depending on the study analyzed. In ROCKET-AF, interestingly, they had a subgroup analysis on patients who had worsening renal function defined as a greater than 20% drop from screening. In those patients, again, no difference was found in major or non-major bleeding or the risk of stroke / systemic embolism. In Aristotle, in the apixaban arm, there was no difference in either stroke rates or bleeding. And ENGAGE, interesting enough, no subgroup analysis was done for patients with a creatinine clearance less than 50. This led to the thought that our oral anticoagulants, the newer ones, DOACs, more efficacious and safe in comparison to warfarin in patients with CKD. So this trial looked at a meta-analysis comparing oral anticoagulants and AFib in patients with renal impairment, including advanced chronic kidney disease with a creatinine clearance less than 30. This was a large study. They analyzed over 120,000 patients, and then they found that DOACs actually significantly lowered the risk of stroke or thromboembolism and major bleeding when compared with warfarin, regardless of the severity of renal impairment. Interestingly, potentially related to the dose reduction of edoxaban, that's the theory, was that edoxaban had the largest reduced risk of thromboembolism and stroke, followed by apixaban, but apixaban had the lowest risk of bleeding. The highest risk of bleeding was dabigatran. Actually, dabigatran was potentially have a higher risk of bleeding in comparison to warfarin in patients with CKD. Of note, hemorrhage occurred in almost 15% of patients, and similarly, as known that almost 50% of patients will actually pass away in 2.5 years when diagnosed with end-stage renal disease. This is similar to the population-based studies. Specifically looking at highlighting unspecified DOAC, you can see in comparison to warfarin, there was a trend towards improvement, and major bleeding, apixaban by far had the lowest risk of bleeding overall. However, all-cause death and mortality appeared to be unchanged between DOAC and warfarin therapy. Overall, this makes sense, given the pharmacokinetics of apixaban, given it has the lowest proportional renal excretion at almost 25% in comparison to the other DOACs, is likely the safest medication to use in end-stage renal disease, or CKD. And it makes sense that dabigatran has the highest risk of bleeding in these patients because it is the highest renally cleared medication. Just for reference, as this will become important as we go forward, we can see that for apixaban, this is the current FDA guidelines, so not the Canadian guidelines. They actually state that apixaban potentially can be used in patients with end-stage renal disease with a potential dose adjustment based on weight less than 60 kilos or age greater than 80. Typically in Canada, we would include also a creatinine clearance greater than 133 as well. The other DOACs are not recommended with a creatinine clearance below 15. This is a relatively recent study. The combined AF study analyzed about 72,000 patients. It was a meta-analysis to evaluate the safety and efficacy of DOACs versus warfarin across the creatinine clearance spectrum. It included patients with down to a creatinine clearance of at least 25. It found that DOACs, in comparison to vitamin K antagonists, derive a larger efficacy benefit as the creatinine clearance decreases to at least 25, with similar trends for both death and intracranial hemorrhage. Of note, and the reason I mentioned earlier, at times patients will be dose reduced without the aforementioned clinical criteria of age greater than 80 or weight less than 60 kilograms. This study found that those patients likely actually have increased risk of harm. So indiscriminately dose reducing DOACs and atrial fibrillation likely increases the risk of stroke and thromboembolism without significantly reducing the risk of bleeding or intracranial hemorrhage. I highlight this graph largely to see that as creatinine clearance worsens, as mentioned earlier, the risk of major bleeding significantly worsens. Now note these graphs actually cut off at a creatinine clearance of 30, but you can see the trend in intracranial hemorrhage is that DOACs likely have superiority over warfarin in this patient population. Interestingly, in major bleeding, though it was not statistically significant, but in stroke and systemic embolism it was, and potentially in death. This suggests that the benefits of DOACs over warfarin are potentially amplified as kidney function worsens, with increasing efficacy and trend toward greater safety. Therefore, these studies suggest that in patients with declining creatinine clearance, DOACs potentially are safer and more efficacious in comparison to warfarin. Specifically, apixaban appears to be the safest medication given it has the lowest renal clearance in comparison to other DOACs. However, the question remains, are DOACs safe in end-stage renal disease in patients with atrial fibrillation? So this is a study that many of us were looking forward to. It was a Renal AF trial, which actually randomized patients in a blinded fashion to either apixaban versus warfarin. The apixaban dose used was 5 milligrams twice a day. The patients need to have at least a CHA2DS2-VASc score of greater than 2. Only 154 patients were randomly assigned, 82 to the apixaban arm and 72 to the warfarin arm. Unfortunately, the study had to be stopped early because of enrollment challenges. The average CHA2DS2-VASc score in this population was 4. Of the patients studied, there was a significant amount of patients who experienced major or clinically relevant non-major bleeding. Almost a third in the apixaban arm and 26% in the warfarin arm. Interestingly, in comparison to other studies and where the time on treatment for warfarin is typically around 60%, in this study was 44%. So potentially the risk of bleeding was underestimated in the warfarin arm in this study. The risk of stroke and systemic embolism was quite low at 3% in the apixaban arm and 3.3% in the warfarin arm. And this will be touched on as we go further in the presentation today. An important arm to include in these trials is would no treatment be as effective as anticoagulation treatment. The authors of this study concluded by saying clinically relevant bleeding events were 10-fold more frequent than stroke or systemic embolism among this patient population on anticoagulation. So given the high risk of bleeding in the hemodialysis population and the lack of randomized trials, future studies should compare anticoagulation with no anticoagulation, as there remains uncertainty on whether there's a role for chronic anticoagulation for patients in atrial fibrillation. And again, you can see in this trial that there was a significant rise in bleeding the longer patients were on anticoagulation. And this is only within the year. There was no statistical significance between the apixaban and warfarin arm. So just wanting to take a step back, this 2020 study actually looked at whether apixaban versus no anticoagulation, which was a retrospective review, does apixaban reduce the risk of cardioembolic events? This analyzed about 521 IHD patients on apixaban versus age-matched controls on warfarin, which is about 1,500 patients. Primary outcome was admission for new stroke, ischemic or hemorrhagic, TIA or systemic thromboembolism. Secondary outcomes including major clinical bleeding. Compared with no anticoagulation, apixaban was not associated with a lower incidence of the primary outcome. However, a significantly higher incidence of fatal or intracranial bleeding was observed with the apixaban arm compared with no treatment. Taking a look at the trials here, so any stroke includes hemorrhagic stroke. You can see that compared to no anticoagulation, there's a significantly increased risk of bleeding for patients on apixaban. When compared to the 2.5 dose, there seemed to be no difference in systemic embolism or stroke. The graph somewhat cuts off here, but in the 5 milligram BID dose, it appears there's no difference in ischemic stroke or MI if a patient takes 5 milligrams twice a day. However, in the adjacent graph, in the 2.5 dose, it appears that they actually have a higher risk of ischemic stroke or MI, suggestive that there's increased risk of mortality in these patients. And again, mentioned earlier, the risk of fatal or intracranial bleeding was significantly higher in the 5 milligram PID arm, but not in the 2.5 arm. This is similar to previous studies in which we looked at warfarin in patients with atrial fibrillation and end-stage renal disease. This is a classically cited study as whether warfarin is efficacious and safe. It was a retrospective review done in 2016 and included patients with a creatinine clearance below 15. You can see typically up to a creatinine clearance of above 15, the risk of bleeding obviously increases, but it significantly increases from a creatinine clearance above 15 to below 15, highlighted by this purple dotted line here. But the risk of systemic and thromboembolism doesn't significantly increase with a reduction in GFR. And highlighting the bottom portion of this graph, you can see that versus no anticoagulation, warfarin appears to have no difference in stroke and thromboembolism, but a statistically significant difference in the risk of major bleeding. Similar to the Renal AF trial, this is another trial that I was looking forward to help answer this question. This trial unfortunately only randomized 97 patients to either on chronic hemodialysis to either apixaban 2.5 or vitamin K antagonists. The endpoint measured here was first prevention of major bleeding, all-cause death or non-major bleeding. Efficacy primary endpoint was either ischemic stroke, all-cause death, MI, or VTE. The authors hypothesized at this time that apixaban was not inferior to warfarin. The study found that there was no difference in safety or efficacy were observed between apixaban 2.5 versus vitamin K antagonists, in patients with AFib and on IHD. Nearly half of the patients randomized had one safety event, either major clinical bleeding, non-major bleeding, or all-cause death. The authors concluded that apixaban 2.5 showed no apparent difference in safety. However, due to challenges with enrollment, the pre-specified non-inferiority test could not be met. So similar to the Renal AF trial, challenges with enrollment affected the ultimate results. But you can see here, the apixaban is highlighted in the yellow portion of this graph, while warfarin is highlighted in the, or vitamin K antagonist is highlighted in the blue. And you can see there's no statistical difference in stroke and venous thromboembolism or the risk of bleeding. Therefore, it appears apixaban in patients with IHD has similar bleeding outcomes in comparison to warfarin. However, previous studies looking at apixaban and warfarin suggest using anticoagulation in patients with AFib/end-stage renal disease does not change the risk of TIA/stroke. Therefore, the question remains, does any form of anticoagulation efficacious and safe in patients in this patient population? There is an upcoming study based in Toronto and Australia. It's called the safety study. It's currently a pilot trial, mostly to see if they're able to recruit enough patients. Looking at trials.gov, they've recruited about 151 patients so far. Hopefully they're able to recruit enough patients, and this will finally answer the question if anticoagulation is safe to use in patients with AFib and on IHD. They actually will include both warfarin, apixaban, and no anticoagulation. They don't comment on how they will dose reduce 2.5, but I assume it's due to the pre-specified age greater than 80 and a weight less than 60 kilos. Using this evidence, the ACC guidelines give a pretty weak recommendation to be that potentially patients may receive some benefit with anticoagulation with a creatinine clearance less than 15. But again, this is based on low quality studies. There are no guidelines on the use of low molecular weight heparin in the setting of AFib and end-stage renal disease, likely related to the fact of cost and, as I go into earlier, also limited evidence. Despite the clinical equipoise on this, it appears the FDA has approved apixaban 5 POBID and rivaroxaban 15 daily for patients on end-stage renal disease. There are multiple opinion papers. Some nephrologists use 2.5 twice a day. Some use Riv 10 once a day. It's not typically something that I see used routinely here in St. Paul's or BC in general, and unless the patient has very significant challenges with warfarin. Despite no studies done in end-stage renal disease, an option is for patients who have high thromboembolic risk and increased risk of bleeding is left atrial appendage surgery. Now talking about VTE, beginning with DOACs. The evidence for DOAC and VTE in end-stage renal disease is very limited, with no RCTs published to date. Therefore, much of the information garnered in the major RCTs, or garnered from the major RCTs mentioned earlier. For patients with end-stage renal disease, the data is primarily from retrospective reviews. So talking about the first retrospective review, this was a apixaban versus warfarin in end-stage renal disease diagnosed with acute VTE. It examined about 11,000 patients, 2,000 on apixaban and about 9,000 on warfarin. They analyzed patients from 2014 to 2018 and included patients primarily on IHD or PD. Now of note, 94% of patients were on IHD and only 6% of patients were on PD. So this study primarily will comment on patients on IHD. Patients are study who are newly initiated on apixaban or warfarin for acute VTE. Here, apixaban is highlighted as the blue line, while warfarin is highlighted as the yellow line. Here, warfarin was found to be inferior to apixaban, and apixaban was associated with a lower risk of major bleeding, intracranial bleeding, and GI bleeding. Recurrent VT and all-cause mortality were not significantly different between the cohorts, In about 10% of patients will in the apixaban arm experience major bleeding versus 14% in the warfarin arm. The risk of ICH was 1.8% in apixaban versus 2.5%. Interestingly, the subgroup analysis found that apixaban 5 BID versus 2.5 showed a reduced risk of major bleeding with a potential similar risk of VTE recurrence compared to warfarin. One thing that not mentioned in the study and as a limitation is what the loading dose given to these patients was. It's unclear if they were started right away on 5 twice a day, were they given the 10 twice a day for 7 days, or were they given something else as a loading dose prior to the initiation of DOACs? Another trial is looking at in a similar patient population. This one had about 12,000 patients as well. And again, it looked at apixaban compared to warfarin in patients newly diagnosed with a VTE. This trial similarly also found that apixaban compared to warfarin was associated with a low risk of recurrent VTE and major bleeding. It was most statistically significant in the recurrent VTE event and barely met statistical significance in the major bleeding event. As you can see here, all-cause mortality crossed a hazard ratio of 1, so no difference was found. When looking at particular subgroups, highlighting here, it appears that the cancer and chemotherapy group experienced the greatest benefit on apixaban versus warfarin, and their risk of recurrent VTE was the lowest, lower compared to warfarin therapy. Now, no, not all studies are unanimous on this topic. For example, this was a small retrospective study about 70 patients completed in Houston and only looked at apixaban patients initiated on apixaban for VTE. It found that the risk of bleeding is about 13% on apixaban, and the recurrent VTE event recurrent VTE rate was about 7.4%. The authors note that this is higher than the landmark trials. Therefore, they conclude that apixaban use should occur following shared care decision-making with the nephrology team and hematology and thrombosis specialists, especially if there's no contraindication to warfarin, because the guidelines would primarily recommend warfarin in these patients. So RCTs are desperately needed to know if apixaban therapy is safe to use in patients with end-stage renal disease. It appears that apixaban may be superior to warfarin in large retrospective studies, but of course these are fraught with their own biases and may reduce the risk of bleeding. Looking at parenteral anticoagulation, at this time there's no RCTs that compare different low molecular weight heparins for patients found to have VTE while in IHD. However, looking at the mean molecular weight at the anti-10A and 2A ratios, one will be able to surmise what the potentially has a lowest renal clearance. Tinzaparin, given its higher molecular weight in comparison to dalteparin and enoxaparin, relies less on renal clearance. It relies mostly on the reticular endothelial system to be cleared. Given its higher weight, and this will become important, is that it has a higher, lower anti-10A to 2A ratio compared to dalteparin and enoxaparin. Given the reduced renal clearance in comparison to the other low molecular weight heparins, tinzaparin can be safely used in a creatinine clearance less than up to 20, and potentially may not accumulate with a creatinine clearance less than 20. While enoxaparin and dalteparin are not recommended when the creatinine clearance is below 30. Therefore, tinzaparin has been primarily the medication studied in a very limited fashion in patients on IHD or end-stage renal disease. This is taken directly from Thrombosis Canada. And again, I just highlight here, there's very limited data based on a creatinine clearance below 20. So I'll present 3 trials looking at anticoagulation in the setting of end-stage renal disease with tinzaparin. This is a trial out of the Ottawa group. He looked at, and published in 2012, it compared tinzaparin versus dalteparin for peri-procedural prophylaxis. It was a randomized control trial where patients were randomized either to dalteparin or tinzaparin and had therapeutic anticoagulation. Anti-10A testing was primarily done after the third dose of low molecular weight heparin. And it's unclear why, but they targeted an anti-10A level of less than 0.2. This was a trough level of less than 0.2. And that was their primary outcome. They found that on patients both with tinzaparin and dalteparin were above this trough level of 0.2, suggestive of accumulation. However, dalteparin was significantly higher in the risk of accumulation in comparison to tinzaparin. Of note, if you look at pre and post dialysis, the amount of anti-10A activity is not statistically significantly different. This is to be expected because low molecular weight heparin is a very highly negatively charged medication, so it likely is not filtered through dialysis membranes. The STRIP study was a very small study. Only 28 patients were studied who received prophylactic tinzaparin for up to 8 days. The primary outcome was bioaccumulation, defined as a peak anti-10A activity greater than 20% on day 5, and a trough level greater than 0.4 on day 5, which was indicative of excessive anticoagulation. Of note, no patient had a 20% increase in their anti-10A activity from day 2 to day 5, or an anti-10A level greater than 0.4, with short-term prophylactic dosing of tinzaparin in end-stage renal disease. Therefore, this suggests that for short-term uses, potentially prophylactic doses of tinzaparin does not accumulate. Now, this is a study being a word used lightly in this case that we all know of. It's called the Trivet study. It was actually never a published study. It was only an abstract. You cannot actually find the actual published study anywhere. But this abstract published in ASH in 2016 aimed to assess tinzaparin accumulation in patients with VTE in varying degrees of renal impairment using serial trough anti-10A level measurements. The degree of accumulation occurring in patients with a creatinine clearance less than 30 was further evaluated by subdividing patients with a creatinine clearance less than 30, 20 to 29, and less than 20. In comparison to the rest of the trials, actually about 150 patients were enrolled over 5 centers. You can see as the creatinine clearance decreases up to hemodialysis, the amount of accumulation increases as well. However, their predefined accumulation level or trough level was greater than 0.5. And that was not observed. So this would suggest potentially that tinzaparin does not significantly accumulate to a trough level of greater than 0.5. Again, secondary analysis or more thorough analysis of the study could not be done because it was never published. This is taken directly from a patient followed in the thrombosis clinic. This patient actually was diagnosed with a catheter-associated thrombosis and had been on therapeutic tinzaparin for 2 weeks. And you can see their trough level was 0.16 consistently, suggesting that they are not accumulating. This is what we consistently will see in patients on tinzaparin and IHD. So we're very comfortable with prescribing it in this population at this time. Therefore, given its size and less dependence on renal clearance, tinzaparin out of all the low molecular weight heparins is the safest to use in IHD. However, of note, these are very small studies, and that it appears it does not show significant accumulation. Even if you look at UpToDate and some of the FDA protocol, they really only typically recommend up to only 8 days of use. That's primarily taken from the STRIP study. To help guide dosing, anti-10A testing has commonly been used. However, in our experience, for some reason, tinzaparin has been found to be subtherapeutic on patients on IHD. This is taken directly from the St. Paul's laboratory, and I had a discussion with our local hematopathologist, Hamish Nicholson. You can see here the primary peak level is thought to be a anti-10A target between 1.0 to 2.0. Now, when talking with Hamish, this is primarily derived from enoxaparin and dalteparin, and not really from tinzaparin. And this is a general recommendation, given the limited amount of evidence on what anti-10A testing to target. Unlike anti-10A testing for unfractioned heparin, there's no perspective data in guidelines to suggest a true therapeutic range for tinzaparin, and on whether and also there's no guidelines to offer advice on safely adjusting the dose if it's not within this range. We do know there's a strong linear correlation between creatinine clearance and anti-10A levels in patients with an enoxaparin after multiple therapeutic doses. And this linear correlation is especially seen with a creatinine clearance less than 30. So taking it directly from the FDA monograph, you can see that the peak anti-10A activity observed in studies is only really 0.87 after 4 hours from after tinzaparin dosing. It never really reaches in between that 1.0 to 2.0 range. This is taken directly from the 2012 CHEST guidelines, who actually have a lower target range for tinzaparin in comparison to enoxaparin and dalteparin. And I'll get into this later on. This is likely related to its greater anti-2A effect and lower anti-10A to 2A effect ratio. The CHEST guidelines actually cite this very small study out of France and Switzerland that's over 20 years old. This study actually noted that different low molecular weight heparins likely generate different anti-10A activities, suggested that specific anti-10A activities for each low molecular weight heparin should be used to know if it is within the therapeutic range. And tinzaparin likely has a different reference range in comparison to other low molecular weight heparins due to its increased size, resulting in increased anti-2A activity. Looking at the guidelines, I do not see any guidelines recommending measuring thrombin time as a measure of effective anticoagulation. And now I apologize for the poor resolution. The study is over 20 years old, and this is the best I could get. And again, you can see in this study that tinzaparin has a lower peak anti-10A activity of 0.85 compares to dalteparin and enoxaparin. This is actually taken from the Canadian monograph, and this actually gives a lower anti-10A activity effect. And it actually cites for therapeutic tinzaparin 4 hours after administration, their anti-10A activity peak was 0.7. When trying to find other health authorities what they do with tinzaparin dosing, the Toronto group and the UHN actually target an anti-10A level of 0.8 to 1.2. And the NHS, seen by the table here, recommend also an anti-10A level of 0.8 to 1.2. So below what our recommendation of 1.0 to 2.0 by our laboratory. Now, it appears that, like I mentioned, tinzaparin does not significantly accumulate in patients with end-stage renal disease on IHD, and likely has a lower anti-10A activity, anti-10A activity measurements needed to know for if it's in the therapeutic index. However, there's always a clinical concern from MRPs and other consultants about accumulation of tinzaparin in patients with end-stage renal disease. So this study aimed to assess whether predefined dose reduction of tinzaparin in comparison to not dose reducing tinzaparin based on renal dysfunction led to anti-10A activity changes. So in one arm, when a creatinine clearance was below 30, they did a 50% reduction in tinzaparin dosing, while in the other arm, they continued at the standard dosing of 175 units per kilogram. This study found that in patients who had dosage reduction, it led to significantly anti-10A levels below the therapeutic level. 93% of patients had a below anti-10A activity less than 0.85, which they measured as the therapeutic level. Interestingly, even in the therapeutic arm, the average median anti-10A activity was 0.74, similar to the Canadian monograph, but below their target of 0.85. Therefore, they concluded that preemptive or dosage reduction of tinzaparin is likely not needed in moderate to severe renal insufficiency, and if anything, will lead to subtherapeutic anti-10A levels and potentially harm. Therefore, in patients with renal insufficiency, they likely should be continuing on routine dosing based on their weight. You can see here, looking at this graph, that reducing the dose of tinzaparin does not lead to subtherapeutic or supratherapeutic anti-10A activity, which would be associated with an increased risk of bleeding. If anything, it's subtherapeutic, suggesting an increased risk of recurrent VTE and extension of VTE. The authors do not give an explanation on why, even in the unreduced dose, why do this population had a anti-10A activity less than 0.85. Again, it appears to be unlikely related to end-stage renal disease because IHD should not clear the medication given how negatively charged it is. Therefore, from limited evidence, it appears that tinzaparin does not significantly accumulate in renal dysfunction. However, the testing used to monitor may not be calibrated. So instead of targeting potentially an anti-10A level of 1 to 2.0, similarly to the NHS and the UHN, potentially a 0.8 to 1.2 peak anti-10A activity should be tested. There's even less data on what the optimal trough level would be. Does it need to be 0.5 or should it be below that as well? Looking at doing a literature review, I could not find recommendations on this. And primarily, the 0.5 trough is again taken from the enoxaparin and dalteparin data. It appears for short durations in end-stage renal disease is likely safe to use. Now, the next steps, I was able to, when I was doing some thrombosis training in Ottawa, I did see the use of some of these medications. The new factor 11 inhibitors appear to have less renal clearance, depending on the one that is being studied, between 8 to 20%, so below the 25% of apixaban in comparison to other oral anticoagulants. There are a number of studies occurring in patients with CKD that have end-stage renal disease. So it'll be interesting to note if there is a role of prevention cardioembolic events and atrial fibrillation in the treatment of VTE in this patient population. So in conclusion, anticoagulation with either apixaban or warfarin for patients with AFib is potentially not required for all patients with end-stage renal disease, and further studies are required. Hopefully the safety study, if it has adequate enrollment, will be able to answer this question if no anticoagulation is as safe as anticoagulation therapy. Treatment of VTE with apixaban in patients with end-stage renal disease appears to be safe, but further RCTs are required, and treatment of VTE with tinzaparin in patients with end-stage renal disease appears to not accumulate in small studies. The anti-10A monitoring parameters potentially would need to be changed. Thank you, and I'm open to any questions, feedback.
Thank you very much, Dom, for this very thorough summary of this issue. You know, you've also presented data that in very small studies that may help us.